One, the cost of the pathologist to look at the tonsillectomy and adenodectomy specimens. Of the 3 clinical advisors, we all 3 handle it differently. All of my group sends everything for micro and gross examination. He sends his for gross only.
ACH is gross only.
Gross only.
Less indicated.
And then Lance in Fayetteville, everything under age 12, he doesn't send for anything. There is no pathology fee unless he has a suspicion.
The caveat would be where they will let me. There are some contractual agreements between pathologists and hospitals that require these specimens to go. In the ideal world, we won't send them. As we discussed, a fairly recent paper that said that I think the cost of pathology for tonsillectomy per cancer that's found on routine pathology is like $670,000, and this was a big meta-analysis. Not one of those patients where they found cancer was it not suspected in advance. So that's just not that anyone's trying to drive anything particularly, but you need to, I think we each need to use this as an exercise to kind of look at the utility of what we're doing and not, just a hassle. So I think that there are going to be some benefits to this, and hopefully to our patients and cost to those patients.
Yeah, my question relates to, let's assume that this works as designed and everyone reaches well below the acceptable range. Let's just say in the commendable range. What happens to the acceptable threshold at that point? Are we seeing let's just drive it down a little further? Because what happens with most things related to quality is that we come up with another measure, et cetera. So I'm just curious what your experience has been and how you foresee this playing out in the future.
Well, there is no experience because this is new. Before I get into that, I just want to also say this exercise here, what we're doing in Arkansas is likely going to be exported other places. If this works, you'll see this being adopted in other states, and so it may not be true in other locations. But having said that, at least from a Medicaid perspective, our goal is not to keep ratcheting things down, and that's not what we're going for here. In the beginning, at least, we're just trying to get a handle of so many aspects of care that we can look at that our goal right now is just to begin the shifting and really have positive incentives. So perhaps on a few things here and there might be some movement of the lines.
A little bit more on the threshold setting from a Blue Cross perspective. If it shifts to the right, everybody wins, and we're happy with that. We do think that you have to look at thresholds over time. For one thing, there's inflationary factors and that sort of stuff, and the cost of healthcare as there is and everything else. But echo Bill's thoughts that that's not our primary goal here. We realize we're better off if everybody gain share, and we're also committed to looking at what. As you saw, we had a limit on the gain share that we were afraid if costs went below a certain amount that the quality would drop off. But we are also willing to look at what people are doing if it's quality care, and they can do it less than that. Obviously, we're looking at that too. That could change as well.
Now, this is not going to solve the Medicaid deficit. What we're trying to do is just, begin to modulate the cost curve. And as I think that Graves was saying, is a potential CME activity. The curve may be flat, but different people are making efficiencies in different areas. And so there are things to take-home messages across the board that people can learn from.
There are 2 charts here that just describe what the distribution of volume of cases look like across the performing providers. So page 41 has this, the breakdown for Medicaid. And just to walk you through how to read the chart, the bars represent the percent of cases in the state for Medicaid that are represented by various providers, and each horizontally is what the overall volume is across different providers. So you can see the first bar at 100% of all volume in the state, there are 64 providers doing that. The next bar there, that 1%, that means is there are 12 providers in the state for Medicaid that had less than 5 Medicaid cases of tonsillectomies. They performed less than 5 over the course of a year. and they collectively represented only a tiny bit, 1% of total volume, which means that, remember, only providers with at least 5 episodes per year are going to be in the model for gain and risk sharing. It means that there are 52 Medicaid providers for this year, this time period, that would have been included. They would have accounted for 99% of the volume in the state. And if you look at each of the subsequent bars, you can see what the split is between different volume providers. So, as one example, providers, the 31 to 60 bucket, 14 providers had between 31 to 60 Medicaid episodes and represented about 14% of volume. The following page 42, is the same chart for Arkansas Blue Cross, and you can see it's a similar look where the 62 providers were those that had at least 5 Arkansas Blue Cross cases, and they represented the vast majority of cases that occurred throughout the course of the year. Just going to go on to a few final pages here. Pages 43 and 44 provide some data on what the post-procedure pathology testing pattern looks like across the state. Page 43, we'll start there, is that chart for Medicaid. The way to read this chart is you can see the 0%, the 1 to 20, the 21 to 40%. That is the percent, the number of episodes for a given principal accountable provider that had a post-procedure pathology test. So for Medicaid, there were, on the right-hand side, 33 providers in the dark blue that had at least 5 cases, that had between 80 to 100% of their cases, all their tonsillectomy episodes, had a post-procedure pathology test. And over there, that represented about 3/4 of Medicaid episodes. Whereas on the left-hand side, you'll see, 2 providers had between 1 to 20%, 12 providers had between 61 to 80%. So you kind of see what the distribution here looks like. It's a similar curve if you look at page 44 for Arkansas Blue Cross. Again, the vast majority of episodes and providers had between an 80 to 100% rate of post-procedure pathology testing, and fewer towards the left-hand side. To the comment before, I would ask if folks have any observations or questions. Is this what you would expect to see? I see a hand over there.
For those who are hospital-based, much of the decision for performing pathology tests is determined by your medical staff bylaws and some of the criteria they use for tissue versus non-tissue cases. And if I'm not mistaken, many actually in hospital bylaws are those policies where I've worked have included tonsils in that. So it's going to require going back to hospitals and saying, this is going to affect everyone, but particularly the provider, obviously. So that's something you'll need to consider. There's a little more groundwork to be done, probably. That'll sneak up and catch you if you're not aware of it.
Great point. Thank you for that.
That's the point of the episode, is to identify things like that, which may be not necessary. And so, so we're actually hoping that those kind of conversations happen. So the whole point of these episodes is to get people to talk to each other, talk to their institutions about things that maybe could be done differently.
Same sort of chart as we just went through, except instead of the post-procedure pathology rate, this is the post-procedure antibiotic utilization rate. So you see here on page 45 for Medicaid, the distribution, 21 providers had between a 20 to 40% post-procedure antibiotic rate. That represented about 2/3 of all Medicaid cases. About 23 providers had fewer than 20%, lower than a 20% post-procedure antibiotic rate. That represented about 30% of total episodes, and a handful of providers had above a 40% post-procedure antibiotic rate. representing about 10% of episodes. If you look at page 46 for Arkansas Blue Cross, you see a distribution which is slightly different. You see 23 providers, or a spike around the 1 to 20% range, but you also see another spike between 40 to 80%, where you've got 26 providers there, accounting for about a little bit less than 50% of volume, 40-something% volume, in the 40 to 80% post-procedure antibiotic rate. So does anyone have any comments or observations?
This is John Jew in Jonesboro. Again, when we're doing the tonsillectomy, adenoidectomy, sometimes we do a sinus irrigation, we do tubes, and sometimes, besides drops, you require antibiotic therapy. Is that stratified for that, or is it not?
Right. No, we were not able to stratify that based on the administrative claims data, because we're looking at the prescription claims, and then prescription claim does not have a diagnosis. So we would define the antibiotics, and if there's a post-procedure antibiotics, it will be part of the episode.
As a follow-up question, you see a fairly widespread distribution. So in your experience, I'm just curious, you take 100 cases, what percentage would have a secondary indication? I would not assume that they'd be 80 to 100%. So I'm just curious, do you have in your own clinical experience, what percentage of your cases would have a secondary indication?
I would probably say maybe 5 to 10%, not that 80%, of course.
And also, as you're going through that previous slide of comorbidities and potential risk factors and exclusions, we are excluding the cost of an unrelated procedure that was performed at the same time, but we may not currently be excluding that entire episode. Or if there's something like this where there is a clinical indication that there would be an increased cost because of that comorbidity or that additional procedure that might warrant a risk adjustment, this would be a good time to kind of give us that feedback so that we know what within the episode we need to look for as a potential exclusion.
Steve Cashman in Fayetteville. Again, I think one of the things that ought to be excluded would be antibiotic ear drops, because certainly that can be a big expense in patients, but that would obviously not be related to true oral antibiotics. It would just be for the ear infections.
So I just had a question. Are we excluding episodes with tubes? The episodes with tubes, the tubes are excluded. At the moment, the question is, are there exclusions for specific type of antibiotics? At the moment, in that 30-day post-procedure rate window, any antibiotic in that window is currently included. I just heard a suggestion about excluding antibiotic ear drops, which is a helpful suggestion. We will look into that. Thank you.
I think that when we looked at the medications for post-op, the included things were going to be antiemetics, steroids, antibiotics, and what was the one other thing? And narcotics. And everything else was going to be excluded. Only those medications would be included in the episode. So if you were using drops because you had done tubes, it would be excluded, if I'm correct on how they were going to design it. And looking at the antibiotic thing anyway, the antibiotic cost is a negligible contributor to the cost. It's great for reporting to see what other colleagues are doing, but it's a $4 generic, and compared to the rest of the cost, it's less than 1% probably of what we're doing. And so it really is not that big of a deal. It's great to know what your colleagues are doing now.
I'm Melanie Smith. What about preoperative antibiotics, IV antibiotics given? Included or not?
Those are excluded right now. There's no RX or antibiotic in the post-procedure period. Pre-procedure period.
Rick Snyder with Arkansas Blue Cross, and one of the topics that, particularly when you're discussing elective procedures, I think I'll at least be mentioned is it's another force on this whole thing of cost and healthcare and quality is transparency. And the bulk of Blue Cross's business are self-funded groups that write their own checkbook. They can see the cost, that every bill and every claim that comes from every hospital in the state, and they know what they're paying, and they're not always satisfied with what they're seeing. And as time goes by, you'll see more and more of that information available publicly. Right now, someone can go on Arkansas Blue Cross website, put in tonsillectomy, your zip code, you choose the radius you're willing to drive, and it'll come up with a list of hospitals and average cost. I think the data now is stated for 2010, I think. But this issue of transparency, for those of you who are working at facilities that you're thinking the facility needs to work with me on this, one force for them, and they're aware of it, is this information is more and more available publicly, and customers will, whether it's a business or an individual, will have more information to make a decision about where they want to have procedures done.